Thank you so much for being here. These couches are really nice to be here. My presentation is about the futures of the patient with DD and the recommendations for treatment. I would try to summarize because I had a long presentation, but I make like a cut, so I hope you enjoy it. In the first place, I'm going to talk about what ADD is, the futures we see in the patients, and the recommendations for treatment. The second part is more or less a summary about the research we are doing. So I think it's quite interesting. So as we all know, ADD is the coexistence. Yeah, sorry, I forgot about you, sorry.
I'm trying.
As we all know, ADD is the coexistence of drug use in a problematical way and a psychiatric diagnosis. I know that here you use the term dual diagnosis more frequently than disorder, but for looking for data, for papers, and for doing some research, we are being encouraged to use dual disorder instead, because in English papers, dual diagnosis can mean any type of disease, both altogether. So sometimes you go in PubMed on places like that, and you put dual diagnosis, and it appears, I don't know, diabetes plus X. So this is an idea that I would like to translate, at least for you when you want to look for up-to-date information. As we also know, these two disorders can interact and influence one each other, and the prevalences depend on the samples we are looking at, but we know more or less that the rate is up to 50. And I would like to highlight that in our research, it depends on the centers we work with, but the most prevalent disorders we observe are depression, anxiety, and schizophrenia, especially. More or less, these changes depend on the way the network is functioning, because sometimes psychotic patients or clients are put in the first place in the public mental health services. So it depends on the time of the year or the phase that the system is on, the prevalence of the different psychiatric diagnoses you may find. Also, the most prevalent drugs we have in Spain are the combination of alcohol and cocaine together. Right now, we are observing as well a rising in the opioids use, that is also frequent. But normally, the drugs most used are these two ones, and of course, THC. Next one. Sometimes we get the question about why these two disorders are coexisting and we are finding this together. There are more or less three explanations, and the last one you observe here is the one who is having right now more support in the data. The first explanation that we have is that people have common risk factors that make them more vulnerable to both addiction and mental health problems. These factors could be from genetic, environmental, experiences, and so on. The second explanation is related to the self-medication hypothesis. This explanation is related to the existence of the mental health problem before addiction and the use of drugs to cope with mental health problems. And in the second place, we have the negative consequences of drugs, the consequences in the brain, in the social network, in the habits the clients have, are the ones who contribute more to develop a mental health problem. Because having symptoms is not the same like having a diagnosis. And this last theory is the one that today has more support. We are finding in a lot of cases that addiction functions as a precipitant factor for the mental health diagnosis for the problem. Okay, now it's mine, it's not working. Okay, so I'm going to make some ideas about the futures of the patients we are studying. In the first place, we have that they have increased severity and complexity. They are clients or patients very challenging for both the groups and the caregivers. The disorders interact and they have a reciprocal relationship. So sometimes the symptoms overlap. And this is a challenge when we have to tailor treatment. Very important, the third box, because we consistently are seeing and finding that DD patients or clients have a very important suicide risk. And this is something that we think that we have to address directly in treatment. As caregivers, we don't have to be afraid about this topic. These clients also have more relapses than patients with just drug use. And of course, therefore, the risk of overdose is more important. And one of the special problems this kind of client have that psychosocially speaking, they have characteristics that are themselves associated to poor treatment outcomes. Because sometimes, next, we see that normally they are unemployed, they have more medical comorbidities, they show a high severity of addiction when you compare with patients with just drug use. They tend to be single, they tend to be men, but this is because of the stigma associated to women seeking for drug treatment. In Spain, up to 50% of the patients with DD we have show polydrug use as well. Not all the time, but they show an important history of this. And as a maximum, they have achieved the primary level of education only. And this also makes this, can we go to the, before? No, the other one. This. The psychosocial limitations are also limited as well because of the level of education they have. Now to the other one. And I don't remember if I also mentioned that they are unemployed. In Spain, it is true that we have some kind of advantages regarding dual diagnosis clients because a big part of them, especially if they have psychotic problems, they have like a disability pension associated to the mental health issue. So it's not a lot of money, but at least it's a kind of money they receive that allows them to have the basics. Next one, please. And with this in mind, I would like to talk about the research we are doing. We have a very important area that is personality, but not personality from a disorder point of view, of a categorical one, but from the point of view of the traits. When we study patients with DD and compare them with patients with only drug use, we see that patients with DD have higher scores in that traits you have there, and these are all traits associated to relapses, severity of addiction, more problematic behaviors, and important difficulties for managing distress. Besides, they also tend to present a profile that is associated to get isolated when we need help, as well as with some difficulties for being in touch with large groups of people. I would also would like to highlight that the personality profile of patients with DD, I say patients because in Spain it's not so very frequent to mention clients, but the personality is more, leans more toward a profile of an addicted person than to the profile of a person with a mental health issue. So DD from only drug use in personality is not very, very different. They have more remarkable traits that are problematic, but it's not very significant, let's say. In the other area, that is neuropsychology, this is the way they think, they reason, they pay attention, they memory things, they new things verbally. In this case, we see that they are really impaired. They have a lot of troubles. And this is an important topic because if the clients we have problems for planning, reasoning, thinking about the future, paying attention, and memorizing stuff, what do you think? They are going to have a lot of problems, follow our treatment properly. From the group of DD clients, the ones that show the worst performance in these functionings are the ones with psychotic issues, the ones with schizophrenia. In fact, sometimes dual schizophrenia shows some characteristics that are very similar to people with dementia. And this is because it tends to be a chronic illness, and if you add that to drug use during your life, your brain suffers a lot. Next one, please. Other relevant findings, I tried to make a briefing about our research and interesting things that I found in the last 5 years. And another topic is the history of psychological trauma that is strongly present in clients with DD, especially when they are women, of course. This also gives us the idea about the importance of including in the treatment programs. I know it is not easy because sometimes we tend to think in including a lot of things and it's not possible. But this data give us the thought about including specific trauma approaches with this type of client. And the last group of findings I would like to comment here is the part of chronobiology. This is not very known. It's a part of psychology and biology that work together. And it's the part that studies the way human functions. We have a circadian rhythm that is up to 24, 25 hours per day. And we have been consistently finding that having a morning type, being a person that functions better during the morning, that wakes up early, that have strong activities during the morning, and start to progressively rest towards the afternoon, is a protective factor for addiction. So this is something that treatments should try to invite. Dual diagnosis patients, it is curious because when they enter treatment, they have problems in sleeping and in wakefulness. They have problems in both the way they sleep, but also in the way they are awake. But as it says in the last part, sleeping patterns show a faster recovery. So when the client passes 3 months under treatment and it's in a stable condition, their sleeping pattern gets better. However, the wakefulness is not adequate. They are awake, but physically and mentally speaking, they are not with an activation that helps them to follow all the things they have to do. That's why we also try to encourage treatments to have regular schedules synchronized with a light and dark cycle. And it is very important to encourage our clients to do outdoor activities even we don't have sun. This is a protective factor as well, and helps them to put order in their biological rhythms as well. And next, please. For us, it's also very important to address the part of gender perspective, because up to date, treatments for addiction and of course for DD clients have been addressed to men. And we have to have a clear idea that women also have DD and addiction. This is not happening to them. They have a lot of difficult times to look for help. They are very stigmatized. They present a pattern that it tends to be more related to anxiety and depression and to borderline personality disorder as well, at least the clients we work with. They present also a very high level of benzodiazepines use. For general practitioners, at least in Spain, it is very easy for a woman to go to the doctor, says she has anxiety, and they gave this kind of pills. And with a supervision, this can be very dangerous. And women present telescoping. That is a phenomenon that we have been observing. That is that they need a shorter time compared to men for the initiation of substance use to having addiction and to entry treatment. Their prognosis is worse and faster. Besides gender roles, female gender roles can also act to precipitate DD, because being a woman gives you vulnerability factors that are related to addiction and mental illnesses as well. In this point, I would like to make some treatment recommendations, considering the research I presented and all the things I read for today. Next one, yeah. In the first place, we consider that, first of all, a comprehensive assessment must be done. I know here I put a lot of factors, and I know that professionally and practically speaking, it's quite impossible. I am aware of that. But at least we have to open our minds and not only do the clinical and psychosocial assessment. There are some extra factors that we should be taking into account as well, like suicide risk, the neuropsychological functioning. I know that this sometimes can be strange to listen, but it's important to know with the raw tools we are working in. And if someone is not able to follow chains of reasoning properly, they are not following the therapy in a good way, but it's because they can't. But these functions, the good thing is that we can recover them with training. And also health-related quality of life, because with some short interviews or questionnaires, in a very short period of time and in a cheap way, because this is pen and paper, we can find exactly which areas of the quality of life of these clients need to be improved more than other ones, because our idea is to tailor programs to their specific needs. And also we are we are kind of strict of waiting 4 weeks with the client in abstinence to establish a psychiatric diagnosis. And it's a time that we should wait. Once the assessment is done, the treatment interventions have place, and we don't have to forget about relapse prevention and follow-ups. what the data is telling us is that the more progressive the client is discharged, the more progressively they are apart from the treatment and the contacts, their prognosis is better. The ones who have more problems after they finish their programs are the ones that don't have a follow-up from the caregivers. This morning we have been spoken as well about integrated treatment. We now know that the results are better than the models that treat both conditions sequentially or in parallel. But we don't have to confuse integrated treatment with treating everything at the same time, because this can be frustrating for the client. We can program different stages or different sessions or groups on which we are putting more attention in addiction or mental health, but an integrated approach doesn't needs to have therapy for the both problems all the time. Multidisciplinary groups are needed, of course, and treatment has to have, in the first place, the safety and stabilization of the client. Both psychotherapy and pharmacotherapy are needed, is the most frequent situation we find. And in both cases, these two treatments or approaches have to be thinking in long-term recovery. And clients need to know that this is not like having antibiotics some days and then you forget. And in the networks, this has to be present as well, because we are speaking about people who need a lot of follow-up. And sometimes it's controversial. The urinary control analysis, in some places it is not seen with good eyes, but it's not a measure that has to be taken during all treatment. But the data tell us that when these controls are done, the compliance of the client is higher. So this is something, maybe with some client it gets the opposite effect, but in general the research is saying this. This one. Okay. Here I also wanted to make a briefing about the recommendations. The treatments receiving the most evidence are the one including psychosocial components like motivational approaches, problem-solving skills, relapse prevention, and family therapy. And family therapy is not, I am not meaning family involvement, because sometimes we have family groups, but it's not family therapy. And the most expected thing is that once the client ends the program, they are going to be in touch with the family. And if this family have pathological dynamics or patterns, what is going to happen? Also, several treatment goals are needed as well, and this is the summary here. Housing and employment also needs to be addressed, and sometimes it's better for these clients to have someone that helps them with their relationship with the justice system, because this is very frequent for them to have this kind of problem. And to finish my presentation, I will also say some highlights about gender perspective. What we are able to say that it's recommended or better, it's to create groups specific for women, in where we can address gender stereotypes, childcare and parenting skills, because until now, women are the one in charge of children more, so they have other needs. And also to create a safe space for them to address the traumatic experiences they may have. And that's it. I thank you all for being here, and thank also to Proyecto Hombre that I'm here because of them as well, and to the entities that they make us, give us the funding to do the research. Thank you very much.
Thank you, Julia, for your presentation. It was very interesting.
Thank you.
Now it's time for your questions. You can make them in English or in Czech, and I'll translate. I'm not able to speak any other language, so please feel free. Nabízím překlad do angličtiny pro toho, pro koho je to jednodušší to udělat česky. Přeložím vaše dychtivé dotazy. Moc ráda. Využijte jedinečné příležitosti.
It was good to cut some slides, because otherwise
very,
it would
very,
be
very
lovely.
easy, smooth, yeah. So I'll start. What do you think is the most important thing for the clients to continue the treatment? What is their motivation, or what do you think if you do the assessment with them? What would they say? What is the power, or their?
You always made some very difficult question for me. It's good.
I'll try it later better.
No, it's good. I think that they need a reason for recovering and for being out of the program. Something or someone needs to be waiting for them.
Ptala jsem se Julie na to, co je pro ty klienty v léčbě nejdůležitější, proč vlastně v té léčbě zůstávají, co je ta síla, co je jako pohání nebo motivace. A ona říká, že to je ta úzdrava nebo to zotavení a to být pryč z toho programu. Be out of the program.
Yeah.
That's what makes the humor. Yeah.
She is. I just want to ask you how we were talking about the halfway homes and the halfway jobs before. If there is some time you think that the half-time job, or not half-time job, but the job on a halfway or the halfway home is the best for the clients to be in. I mean, if it's half a year or if it's a year, if you have any of these impacts or if you see them.
Regarding, I cannot make an affirmation about the best time for them to have this, but when they do this, they tend to be more independent. In these flats, they can go for a period of time, and this helps them a lot. But I couldn't say an exact time that they could be here. Sometimes, if they have a structured family, it is even better for them to go with them instead of going to this kind of supported or shared living flats. This is not very frequent.
And if you have any systemized program, for example, for the dual diagnosis, that is focused on the job training and on the living skills.
Yeah, but this is not done, and at least as far as I know, this kind of training is not done within the program. Once the client finishes the program, they are referred to some services that in Spanish is called pre-laboral, that is like before working. And they do like these workshops. They have sometimes psychologists or social workers. And I'm remembering, and this is more prepared from the unemployment services in coordination with the psychologist, but it's not, we are lucky we have quite a network. So these skills are trained, but not within the DD programs themselves. Yeah.
Thank you.
Sometimes in the programs, they help them to do some basic things for looking for a job, but the special part is done in other services, like more the city town halls or that kind of part.
Sorry. I just wanted to ask, what are your standards for the post-dual diagnosis program, as in terms of them going after the recovery, and how long does it take? What are your expectations for the person before you can say that they manage to recover fully?
Recover fully? Or
like to the possible way of becoming, let's say, a normal part of society?
I don't know. sorry. More or less, the minimum, the best results are observing in clients that have spent 9 months in the disease, for example, 9 months. If these were in ambulatory or outpatient programs, you need more time. And as far as I remember, it is established that once the client or patient has passed 1 year without important symptoms, they are considered to be recovered.
Thank you.
Thank to you.
Tak máme ještě nějakého dalšího zájemce o dotaz, jste takhle vzadu? Tak já možná, Market, ještě dám tobě na chvilku mikrofon, jestli nechceš shrnout pro ty, co neumí anglicky. Ty 2 dotazy velmi rychle, protože nemám moc času. She just asked me to do a short review about the questions. I don't remember them, but I'll try my best, okay? And I was asking about, was it about jobs, like halfway jobs? And what's the good time of spending in like shelter housing or something? Yeah, was it about that? Yeah. Anna se ptala na to, jak je to s nějakou jakoby podporovanou nebo chráněnou prací a tím chráněným bydlením, co těm klientům víc pomáhá po té léčbě, když zůstanou. A Julia říkala, že vlastně to záleží na tom, jestli ty klienti nemají třeba jako dobře nastavenou rodinu, že pak pro ně může být výhodnější být v těch rodinách. A že v těch programech se nedělají přímo specificky jako pracovní programy a že se to dělá potom, že oni mají na rozdíl od nás štěstí v tom, že ty klienti po ukončení léčby jdou do služeb, jako který u nás mají dělat úřady práce, ale nedělají tolik, jako by měli by, ale je to jako příprava na práci, nemůžou dostávat nějaké rekvalifikace, prochází nějakým psychologickým testováním a tak. A Viktor se ptal na to, jak dlouho trvá, než se ty lidi plně uzdraví, což mi přišlo jako krásný dotaz. A Julia říkala, že to je těžko říct, co to je ta plná úzdrava nebo to plné zotavení, ale že když ty lidi vydrží 9 měsíců v komunitě, takže výzkumy ukazují, že vlastně potom mají daleko větší šanci fungovat v běžném životě. A když vydrží v ambulantních nebo těch stacionárních programech, je to delší doba. A když vydrží rok bez nějakých závažných výpadků, tak je velká šance na plnou úzdravu. Jestli jsem něco... Určitě ne. Tak prej určitě ne. I would like to thank you again for coming here. It's a big honor for us
invitation. I'm
to
very happy
have
to
someone who's doing the research and giving us data about the necessary of our services. And we need more cooperation with universities to do more researches to show how important it is to run our programs. Thank you very much. It was
Thank you.
Thank you.
Thank you.